Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show. Today, bringing another really fascinating guest for you who's involved in creating a better tomorrow for many people out there. We are headed back on our what I call a virtual road trip today, headed over to Fiji, and have the honor of being joined on the show today by Dr. Mark Jacobs, who is the Director of Pacific Technical Support and World Health Organization representative to the South Pacific. He was appointed to this particular position back in August of 2021, and prior to this role has held a series of very senior public health leadership roles. Previously to this, he was the World Health Organization's representative to Lao Democratic Republic from November 2018 to August 2021. Prior to that, from May to October 2018, served as acting director of program management for WHO in the Western Pacific region, and previous to that, director of communicable diseases in the region for the past 5 years. Before joining WHO, Dr. Jacobs was New Zealand's director of public health for 9 years and managed public health programs at the Secretariat of the Pacific Community for 3. Also spent several years in director of public health roles for the state health authorities in Australia. Dr. Jacobs' interests are wide-ranging, including developing healthy public policy, strengthening disease surveillance, strengthening so-called all hazards emergency preparedness, which we'll be getting into, and working across various sectors to improve health. He holds a Bachelor of Medicine, Bachelor of Surgery, and graduate diploma in Health Services Management, as well as a Master of Public Health. And we are going to have with us a lot of really great topics to get into today. Dr. Mark Jacobs, thank you so much for taking time to come on the show.
Yeah, pleasure, Aaron. Bula Vinaka from Fiji.
Great having you. Great having you. Mark, I'd like to start off, if we could, going back a couple of decades, because, I love taking a look at our guests' sort of early work. I think the earliest piece that I came across about you was in something known as the Public Health Bulletin of New South Wales. This was in 1991. You were serving in the Orana and far western regions of New South Wales, and specifically in this paper talking about a infectious disease control program that you at the time were like, this is very poorly coordinated and had to get better. Take us back to the beginning, if you would, and how you got involved in not just epidemiology, but infectious diseases, and sort of where you started off your career.
So, and congratulations on the excellent research, digging back far into the past, Ira. That's most impressive. I started off, I did my medical training in Australia, in Sydney, did a few years of clinical work, but soon worked out that actually what I really liked was working at the population level rather than the individual clinical level. And it actually, it had always been in my mind a little bit, because when I first got into medical school, one of our neighbours in Sydney was a doctor with the Australian Army. And he came over and said, "Oh, congratulations." And by the way, he gave me a skeleton with the property of Australian government stamped on the skull, which was a memorable gift. He also said, I think what you should do, what sort of medicine you should do, is you should go into public health. Well, actually, he said epidemiology, but public health. He said, because you get to travel the world and it's really well paid. Now, I haven't found it to be really well paid, but certainly it's worked from a traveling the world perspective. But anyway, it was always in my head. And so I went back to university, did the postgrad stuff, and then the day that the coursework of what the masters was finishing, I asked one of the people at the university if they knew of any jobs coming up, and they said, "Oh, did you see the one advertised in the western part of the state?" Because the Rana and Far West region is a sort of big rural and remote part of one of the Australian states. It's about the same size as New Mexico. So I also researched that just as a comparison. And I ended up doing that. So it started off being just infectious diseases in a quite an interesting, challenging area. Then a couple of years after that, then the state government set up a system of public health units. So I became the head of that. And so anyway, so that's how I started off. But yeah, the communicable disease side. So I was working. So I started off there in the late 80s, and so I was working on HIV, on hepatitis B. There was quite a lot of mosquito-borne diseases in that sort of area. Lots of sexually transmitted infections, all sorts of things like that. And then moved on to other things once I had a slightly broader role in the same area.
Mm-hmm. Well, I'm always amazed when I talk to public health leaders like yourself about the diversity, let's say, of projects that sort of come across your desk. And again, putting infectious diseases aside for a moment, just looking at the non-communicable stuff that you were involved in, both in the Health and Human Services Department in Tasmania, things like the paint guidelines, ear and body piercing, of course, tobacco control. When you get to the SPC, there's a major dioxin contamination that you got to figure out, not just what's going on, but you got to set up these assays and various screening protocols. Talk a little bit some of that period as well, because I think this background obviously prepares you, for what comes later and all the things you're going to be seeing in a very wide territory, which we'll be getting into what the sort of the Pacific region means for the WHO. But say a couple words about sort of the non-communicable side here, because that's equally fascinating.
Yeah. So, I mean, one of the things I really like about working in public health is that you can be a generalist.
Yeah.
You can work on lots of different things. And I've always tried to have jobs that are very broad. And because I'm big on trying to keep on being challenged by the work that I do and keep on learning all through my career. And one of the best ways of doing that for me is keep on having broad jobs. And so, yeah, some of the non-communicable disease things, and also environmental health things, I guess, to throw it in. Even in the early work, we're doing a lot of work really getting stuff started around a city in a desert area of that state that was a lead mine, and no one had ever looked to see whether there were health issues from lead. So we got that all started. We had huge, 1,000-kilometre long contamination of a major river contaminated with toxic blue-green algae, and there were all these different remote towns using that river for their water. So dealing with that sort of thing. Then from an NCD perspective, I mean, I've done lots of things over the years on things like tobacco regulation, on injury prevention, all sorts of things like that. The stuff that you talked about in Tasmania, so that's where I moved after my first job, so becoming State Director of Public Health there. One of the issues I really focused on there was the legislation was really, really old. It was older than I was. And so that was a big need that we really needed to update the legislation. And public health legislation in a lot of parts of the world is itself pretty broad. And so anyway, we went through a sort of multi-year process to get that done, and it ended up regulating sale of cigarettes. We ended up regulating food safety, nutrition, all sorts of different things in the non-communicable disease space as well as in the communicable disease space. And so even things like skin piercing that I think you mentioned. So that means like tattooists and people doing ear piercings and other body piercings. We put in place some basic rules around how to do that safely. And there were lots of other industries that we worked with. And it sounds like it's like the public health police coming in to tell people what to do. We always develop those sort of very collaboratively with the businesses in that area, and often they actually really were calling out for that sort of regulation because they were worried that other people would be coming in and not practicing safely and would give everybody in the business a bad name. So there was lots of things like that. and we can talk, a lot about different sort of things that happen in Tasmania. SPC, in my time in the Pacific, there's huge issues with NCDs in the Pacific, and I'm sure we'll talk about that a bit later on. So when I was working for this Pacific regional organisation after leaving Tasmania, again, broad job, but a lot on NCDs, a lot on environmental health, a lot on communicable diseases, and then New Zealand doing that National Director of Public Health job again. That sort of mix. Yep. And now when we can dive in more deeply into any of that sort of stuff. There's been lots of interesting things done over the years.
Let's stop at one of those because it reflects on what you're doing at WHO, but I want to go there now beforehand, and that has to do with a very important report that you're involved in 2013. You're at the Public Health Ministry of New Zealand. The title is Integration of Communicable Diseases into All Hazards, National Disaster Management Arrangement. And there's this principle of all hazards. It's a framework that, looks at how we can integrate in a comprehensive approach all potential hazards, some which we were just talking about, some which were coming down the road a few years later. Say a few words about this, because I think this is an important part of what you do in New Zealand and what you're doing now at WHO. But can you talk a bit about the framework?
So, in general terms, I guess it's worthwhile teasing out what we mean by all hazards, because it can actually mean a couple of different things. One is purely from a health sector emergency preparedness perspective. There's not a lot of point having all of these separate plans for individual risks. So like a separate plan for influenza and a separate plan for measles and a separate plan for a radiological incident and so on.
Right.
If they're not all lined up and part of the same system, because we always are faced with these health emergencies, and often our planning is about the last health emergency, not getting ready for the next health emergency. So from a health sector perspective, it's important for us to really think generally about how in general would we respond to an emergency. So what would our emergency response look like in terms of what are the key roles, how would we coordinate it, who would do what, and then we sort of practice doing that in a general way across the health sector. But the other thing that's important is, how does a health sector emergency response fit in with a country's emergency response? Because all of the different countries, they've got national architecture and state architecture around emergency responses. And it includes not just sort of the coordination, but it also includes how do you report to government and what do those structures look like. And New Zealand, and I think it's a real strength of the New Zealand system, it's never had this idea that health emergencies are separate to other types of emergencies that governments have to deal with. It's all part of the same architecture. And so the language of how you deal with an emergency, what are the key roles and things like that, it all lines up, and how do you report up to government, it all lines up. So we know if there's an emergency, whether it's like a cyclone or it's an earthquake or it's a pandemic, we know how the government architecture is going to work. And also we know how the different sectors are going to organise their response. Mm-hmm. And so, for instance, during what generally we call the swine flu pandemic. So that was in my time in New Zealand. So that was obviously going on for some months, and the Ministry of Health was the lead agency appointed by government to lead the national response on that. Now, after a couple of months of this, we basically started burning out some of our capacity, particularly like our health information, our data, our epidemiology capacity in the Ministry of Health. And so we then talked to the Ministry of Agriculture, who also had capacity in that space, and said, can you come in and run that part of the national function? And it was no problem, because they'd already practiced all of the same sorts of roles. They deal with emergencies in the same way. So their veterinary epidemiologists came in and took over the epidemiology, the planning and intelligence function for a national health emergency response for quite some time. So that's the sort of thing that it enables. And of course, the other thing is that there's hardly any big emergencies that only affect one sector. There's always multi-sectoral impacts. And again, on the New Zealand side of things, one of the things when we started thinking about pandemic preparedness, and we were the lead for that. So this is back during when people started becoming first concerned about bird flu. And so the government agreed that there'd be a big focus on pandemic preparedness in general. And we set up about 12 different sectoral groups led by other ministries to really do the detailed thinking about the pandemic impacts in whatever the other sectors were, business sector, border sector, education sector, and so on. And so that might be the Ministry of Education would lead on the education sector planning. Yep. But it was all part of the national planning. And I think the obvious learning from that was that the other sectors really bought into that preparedness a lot more than they would have if it was just the health sector telling them what to do. And I mean, what does the health sector know about how businesses need to prepare? How just in time businesses need to plan for being able to keep important products on shelves during a big disruption, those sort of things. So it was very much about empowering the other sectors to do the planning, but it was part of the bigger picture national planning. And I know the last time I checked, one or two of those sector groups is still running because the organisations that were part of that other sector group thought it was so useful. Then once the pandemic preparedness stuff had stopped, they decided to keep on going anyway. So that's really how you achieve sustainable benefit. You try to design a system so that's meeting everybody's needs and it's in everybody's interests to be active in it.
Perfect. So with that, let's transition now to the World Health Organization Pacific Technical Support Unit, because as you said at the beginning, you're not paid that much, but you travel quite a bit, and clearly in this territory, 46 million people, 21 Pacific Island countries. I don't know the square mileage here, but everything from Pitcairn in the east to Federated States of Micronesia in the north to, I guess, Vanuatu. I did sort of good in geography, but this is no joke of a territory. It's broad, it's diverse. Obviously, the different diseases, both communicable and non-communicable, you're going to be seeing here. Talk about the role, talk about the organization, a little bit of how you made the decision to jump from here from Laos. But please, love to hear the story.
Yeah, sure. So, I mean, it's probably worthwhile me briefly starting on why I made the jump from working in government to working in WHO.
Please.
And I mean, I guess it gets back to what I said earlier on about really trying to keep on being challenged by the jobs that I do. And if I start getting comfortable, that tends to make me think it's time for me to think about what my next job is. Because I do want to keep on working in different ways, working on different issues, working in different settings. And so it got to the point where I'd been doing the Director of Public Health job in New Zealand for about 8 years or so. And I'd already done more or less the same role at state level in Australia for an extended period too. But I still really liked public health. And I'd been having some exposure, more and more exposure to global health, and particularly with WHO. And so I started thinking that that would be an obvious next step. And so then it so happened I was chairing a lot of one of the big annual governance meetings of WHO, and during one of the breaks, I asked one of the senior WHO people at the time if there were any jobs coming up, because I was thinking about trying to make the move. And so then I found out there was a job coming up, and so I applied for that, and I got that. And so then it became, again, within WHO, how do I keep fresh? How do I keep getting challenged? And so I've moved around a bit within WHO. Now, the move from Laos to the Pacific happened because I was asked to make the move by the then regional director. I was still happily being challenged in Laos, and it happened. I moved halfway through the pandemic, and so that was also interesting. So anyway, I got to experience half of COVID in Laos PDR and half of COVID in the Pacific. So I mean, it was an interesting time to move, both from a content perspective, but also in terms of the logistics. But anyway, we probably don't need to get into that. But yeah, so I moved to the Pacific, and I think the Pacific role is seen by WHO as a very complex one because it's a multi-country setting. most of the WHO country offices, and we've got country offices right around the world, almost all of those are just serving a single country. Whereas the role that I've got, or the two roles that I've got at the same time, one being the WHO representative to the South Pacific. So that basically means I'm like the ambassador of WHO to 12 Pacific countries and territories. But then my other hat that I wear at the same time of Director of Pacific Technical Support means we're supporting 21 Pacific countries and areas. Mm-hmm. Mm-hmm. And so because I'd already worked in the Pacific, the regional director asked me when he moved the previous person in this role to regional office. He asked me to move from Laos to this office. So, of course, coming back to the Pacific, I was happy to do it. It was my home part of the world again. But just on the you talked about the size. I can give you a stat for listeners to put it in some sort of scale. The longest distance between two countries that I directly serve, so Pitcairn, which you've mentioned, and the Northern Marianas, is the same as the distance between London and Cape Town. Oof. So that probably puts it in some sort of perspective.
Yeah, it's a territory. I'll leave it at that. So yeah, let's talk about some of what you're doing, because again, quite a diverse portfolio, and I think a great place to start, just because it's been in the press quite recently, is your new pathogen genomics laboratory in Fiji. Clearly, again, the breadth of the geography that you're dealing with, obviously neglected tropical diseases, zoonotic stuff. There was, this Lancet paper just from a couple of months ago on an outbreak of a carbapenem-resistant organism. So the whole AMR theme, which has been extremely hot for us, and in terms of that whole area of surveillance. Talk about the background of when sort of the Pathogen Genomics Laboratory was put in motion, some of the stakeholders, and the importance of building these in-country capacities.
Yeah. So the genomics lab, I guess, as you say, is an example of the broader area of work that we've been doing for quite some time in health security. But really, in a lot of ways, it came out of a big focus on laboratory strengthening. I mean, we've partners like WHO and SPC, the Pacific organization I used to work in. I mean, we've been working on laboratory strengthening with the countries in the Pacific for decades. I mean, I used to work on that 20 years ago when I was at SPC. But really, and so there's been a lot of work done on that. But one of the things that happened when COVID happened was that there was suddenly a lot more resource available, a lot more support from partners for that work. And so we were able to put in place lots more laboratory capacity in the countries, because traditionally there's been limited laboratory capacity in a lot of the Pacific countries, and they rely on being able to send samples away to bigger laboratories. Now, the laboratory in Fiji has always been a bit of a sub-regional laboratory, so a reasonable sized laboratory. There's also been, and still are, quite capable laboratories in places like New Caledonia and in Guam, but also in Australia and New Zealand and Hawaii. And that's where a lot of the samples used to go off to. And of course, that's all well and good, but when you're needing the results to really inform the response you need to be making, like today or tomorrow, and the plane might not be leaving for another week, and then it might take a few weeks to get the result back from the laboratory, well, that's actually not really helping very much. So the need was obvious. And so during COVID, we set up, for instance, a lot of containerized laboratories, so they're able to do genetic testing more broadly of different things, whether it's COVID or dengue or whatever. And so a lot of the countries now have got the capacity to do that basic testing. Now, building on that, that made a big difference to them. But building on that, there's also been a bit of a plan to try to increase the number of countries in the Western Pacific region. So that's the Pacific countries plus basically all of East and Southeast Asia and Australia and New Zealand. There's an aim to try to to reach, I think it's 70% of countries in the Western Pacific region having this genomic laboratory capacity in country.
Mm-hmm.
So as part of that, and with good support, we worked with the of course the Ministry of Health and Medical Services in Fiji, but also with Australia. We worked with SPC, Pacific Community, and we worked with Doherty Institute in Melbourne in Australia to support setting up this genomic laboratory in Fiji at the Fiji CDC. So again, it's part of this broader sub-regional laboratory hub, if you like. Mm-hmm. And the value of that is, of course, it gives very useful information that helps deal with things like outbreaks. So really knowing what's going on. And again, like if we needed to, if for instance, other countries in the Pacific are working towards trying to achieve measles elimination, for instance.
Right.
And so if there was some measles cases happening in say in Fiji, then we wouldn't know whether that's one outbreak that's continuing on and on and on for some time, or in which case that would actually stop Fiji and the Pacific being able to get measles elimination agreed. Or is it actually a number of different introductions of measles from other countries who have got measles, in which case that's still consistent with having eliminated measles. So this genomic laboratory enables that question to be answered. Are all of these cases related, or are they all completely separate? So we don't have to guess on that anymore, and we don't have to wait for a few weeks or a month to get results back from different overseas laboratories. We can find out quickly. And so that then can I mean, the Ministry of Health in Fiji, then they have important information about whether they're dealing with one what we call chain of transmission, so one group of cases that are linked, or whether they're actually just completely separate because you approach them in slightly different ways. Mm-hmm. So it's really practical information that countries need, which makes a big difference to being able to deal with infectious disease outbreaks, cases, really quickly in the future. Now, it's not the sort of testing that you always need. And so if you know you've got an outbreak going on, then you don't need to keep on doing genomic testing. But if it's like in the early days of something, or if something looks a bit unusual, then that's when it's quite useful.
One of the themes, again, that's been more and more important in the last couple of years has been the topic of One Health and sort of the intricate relationship between humans, animals, and the environment in terms of these spillover events. We profiled, we talked about, talking about Australia for a minute. We talked about Hendra and the situation from a couple of years back in terms of sort of the horse vaccination that was going on there. We actually even talked to somebody that was the reverse spillover dynamics. That had the first hippopotamus that caught COVID, but that's a whole other story. But nonetheless, this One Health team extremely relevant. And it was quite interesting seeing a recent paper from the organization entitled "Using the One Health Approach to Fight AMR in the Solomon Islands." And this profiles something specifically called the Western Pacific Regional Antimicrobial Consumption System, looking at national hospital, community pharmacy, antimicrobial prescribing and usage. Obviously, a very important topic, and combined with the need for proper stewardship to make not just to keep away the AMR, but make the antibiotics that we have last a lot longer. What's going on the AMR front, and can you talk about the Solomon Islands, because this is a case study that you recently published about?
So AMR, I mean, it's a huge issue around the world. And in my regional communicable disease director role, if I could talk about that for a moment, that was one of the big things that we were working on, because we were, apart from anything else, we were managing a project looking at resistant malaria in the Mekong countries.
Yep.
And that was a big concern, because there was resistance in a group of medicines called artemisinin, which were like the frontline treatment, and it made a big difference globally to being able to treat and save people from malaria. And so the appearance of resistance to the artemisinins became like this global emergency. And so, it is something that that the organisation does pay a lot of attention to. And of course, actually, AMR. It's sort of, there's AMR that the AMR program looks at, but there's also other AMR issues, like, for instance, resistance for anti-TB drugs.
Oh yeah.
Or to gonorrhea drugs and things like that. There's a lot of work going on in the AMR space, and there are a lot of things driving the AMR issues, and you've touched on some of those already. Now, it could range from you've mentioned animal health. The reason why that's an issue is because antibiotics that are used in people are also often used for animals. It's the same antibiotics. And so just the same as in, like, for both people and animals, if you're not using the right antibiotics, or you're not using them in the right way, so you're sort of using them for people or animals that don't need them, or you're not completing the course, all those different sort of things, or you're using the wrong antibiotic because you're using a special antibiotic that should only be used sometimes rather than a common antibiotic, then that can be, in both of those things, can help drive the development of resistant organisms, resistant bacteria. Then you get into things that you mentioned already, touched on already, things like how easy is it to buy antibiotics, how much control is there of the use, all of those different sorts of things. Plus, also, it gets into the area of infection control, and so a lot of the nasty health facility outbreaks of resistant organisms fundamentally is also driven by breakdowns in infection control in those health facilities. So there's a lot of things all joined together. Now, the Solomon Islands example, I'm not particularly familiar with, but I can give you a different example. I was very recently involved in a process called the JEE, Joint External Evaluation, in the Cook Islands. Now, this is a process, a collaborative process between WHO and a country that volunteers to have some experts come in and help the country look at how strong their emergency preparedness and response systems are, for instance. And so we just recently did that in the Cook Islands. It was a really good process. And AMR and also capacity in the animal health sector is absolutely within scope for these JEEs, these joint external evaluations. And so some of the things that we were finding, we were asking about and finding in the Cook Islands context was in the animal health space. Firstly, so they've got good control over the antibiotic usage, for instance. Also, there's basically hardly any use in animals, and there's no use in animals other than sick animals. So that's a concern in some other parts of the world where they use so-called growth promoters, and so they're just routinely provided to animals. So there wasn't any of that going on. But at the same time, another area in the animal health space where there was a gap was, like all the Pacific countries, there's very, very limited capacity, technical capacity in the animal health sector. And I remember when I first started working at SPC 20 years ago, and I asked somebody about how strong the animal health sector was in the Pacific, and they said, well, there's 5 vets working in all of the Pacific, and 3 of them work here in New Caledonia. So, so there's very limited capacity. And so if you had lots of animals fall sick somewhere, then there's not a lot of capacity in the Cook Islands and a lot of the Pacific to actually go in and investigate what's going on. Anyway, so that's kind of a roundabout answer to it. It is an area that we are trying to work with countries on, but it's another example where you can't just work with the health sector. If we try to tackle important health issues, but only through talking to the health sector, then we're doomed to keep on failing. And we could have the same conversation around non-communicable diseases, and we probably will at some point during our conversation. But it's the same thing. And so, really, to strengthen prevention of antimicrobial resistance, we need to be speaking with the animal health sector. We need to be speaking with farmers. We need to be looking at how the use of antibiotics is regulated in that space as well. We need to make sure that the farmers are getting education on the appropriate use of antibiotics, just like the doctors are and the nurses are. And so it's a big, complicated bit of work that requires lots of people to work together, but that's no reason for it not to happen.
Mm-hmm.
And one of the many good things about working in the Pacific is the bureaucracies are generally quite small. And so if you can't work collaboratively in the Pacific, what hope does the rest of the world have, where the bureaucracies are often bigger? So we have no excuse for not working collaboratively across sectors here.
Mm-hmm. Mm-hmm. And coming back to the theme that we discussed earlier in terms of the all hazards approach, and again, one of the interesting things that you have to deal with and think about in your region is, of course, climate change, and not just what climate change brings. Obviously, climate change impacts the so-called the broad blue economy in your region of the world, but at the same time, many of the diseases, malaria, the dengue, but also the things that are sort of secondary to that. I was joking before the show with Link about when I did the show recently with Craig Venter, and he was, I think it was New Caledonia or something like that, and he decided to eat a fish that had Secretariat toxin, and he got sick for a little bit, and it wasn't a great thing, but ultimately how some of these climate sensitive vectors not just impact us, but ultimately our food supply. Again, we're thinking of the One Health and the broader economy, because I know this is obviously a major part of the economic system down there. Say a couple words about climate change and sort of how you have to sort of integrate that in with your all hazards thinking.
Yeah. So really, the Pacific's on the front line of climate change impacts. The countries are already seeing impacts of climate change, both from a health perspective, but also more broadly, particularly the atoll countries that are super low-lying. And for anyone who's never been to an atoll country, I mean, sort of some of the countries, their highest point is like 1.5 meters, 2 meters above the high tide mark. So it's a very here and now issue, and I was recently in Tuvalu, for instance. It's one of these low-lying atoll countries,
yep.
And I was in the middle of their main town, and there were patches of water on the roads. I said, "Oh, has there been raining?" No, that's water coming up when it's high tide, and it's always there, and I'd be looking around and I'd be seeing all of these banana trees and various other things that looked like they were 3/4 dead because they were being affected by the salt coming up because of because of sea level rise. There are many health facilities around the Pacific that are very close to the sea, and so they're very vulnerable to king tides. They're very vulnerable to when there's a cyclone, storm surges, things like that. It's not a theoretical somewhere down the line issue. It's an already happening issue. Mm-hmm. And we're doing quite a lot of work with the health sectors in particular on that. But of course, that's just a small part of what needs to happen. But a lot of our work is, well, of course, we contribute to the sort of the global advocacy about the importance of action on this. But more concretely, a lot of our work is around trying to help countries strengthen the resilience of their systems, their health systems, and their health facilities. And so, some of the things we do in that space is that we're, for instance, in Fiji, funded by Republic of Korea, by KOICA, there was an assessment of the vulnerability of all of their health facilities. There's 220 something health facilities had their vulnerability assessed, and then particular health facilities were prioritised for action. And now we're working with those prioritised health facilities to really make them more resilient. And so that might be strengthening the actual building itself because it's vulnerable when there's a severe storm coming through. We're putting in solar power and desalination units for numbers of them. Lots of things like this, plus working with communities around trying to help the communities be a bit more resilient. That's even before we get to things like climate-sensitive diseases. We're currently in the middle of a big dengue epidemic in a number of the the Pacific countries, including right here in Fiji. And I've had to warn my own staff in the office here a few times around precautions to take around dengue because it's widespread. But there's plenty of other climate-sensitive diseases as well, leptospirosis, all sorts of different things. And so some of the work we also do is, particularly in places like Kiribati, for instance, again, supported by Korea, we're trying to strengthen both meteorological data collection and health data collection and the linkage between the two, so they can get a bit more of a sense of an emerging threat of a climate-sensitive disease outbreak rather than waiting until the outbreak happens. So there's a lot of work like that, but it's such a fundamental issue in Pacific countries. It's impacting things like, how easy is it for people to access healthy fruit and vegetables, for instance? So there's less and less capacity, particularly in the low-lying countries, to actually grow healthy food locally, which then means that you have to rely on imported food, which is then either super expensive or if it's cheap, it's generally not very high quality, which then contributes to the enormous NCD burden. So it's a very, very big issue for us. And it's another example of how a lot of this stuff is connected.
Right.
And so climate change is important from an emergency perspective, but it's also important from a sustainability of the health facilities perspective. And so it's a universal health coverage, if you like, priority. It's a communicable disease priority. It's an NCD priority. It's a key priority for everything and everyone in the Pacific.
Well, so talk a little bit about the NCDs, because again, reading some of the materials that the WHO has out there for the Western Pacific region, again, like everywhere, we're unfortunately seeing major surges: heart disease, strokes, cancer, diabetes. You mentioned the issue of sort of the food, and I don't know. I know we have a new secretary here of HHS that's really been focusing on sort of the ultra processed stuff. But what are some of the other trends that we should know about that are happening in terms of some of these major, what I'll call, Healthspan killers? And we'll get into the topic of Healthspan when we talk about aging. But what else should we know about, again, this region, which is, again, quite diverse, quite broad? To take us into the NCD realm a bit more.
Yeah, so I guess it's important to start with, it's not all bad news.
Okay.
And I'll get to some of the bad news in a moment, but there's some good trends for some of the NCDs. And so for a lot of the countries, the smoking rates have started coming down. And so that's of course a big driver of these non-communicable diseases like cancer and lung disease and so on right around the world. And so there's been quite a bit of attention on that, and a lot of the countries are like increasing their tax rates on cigarettes, for instance, which is part of the solution, but only part. So that's improved. Management of things like high blood pressure and high blood cholesterol at the primary care level, health facility level, is much better now than it was. So that's also important. And there's also a lot of rheumatic heart disease in a lot of the Pacific countries. So that's a long-term complication of an infectious disease, of strep throat, a particular type of strep throat that doesn't get treated. And so for a number of the countries have got programs around that, which is greatly reducing the number of their people that have to be flown to other countries to have like valve replacements, open heart surgery, those sorts of things. So that's some good news. Where we really struggle in the Pacific, we continue to struggle, is in areas like obesity and diabetes. Of course, they're closely related. So if you look at the top 10 countries in the world in terms of the prevalence of their population that's obese, I think the Pacific is either all 10 or 9 out of the 10, depending on which list you see. It's a lot of obesity and therefore a lot of diabetes in the Pacific, and we see lots of impacts of the diabetes. So like people losing their foot because of amputation, because of diabetes complications, kidney failure, problems with vision, all of those different sort of things. They are pretty common here. And people have been worried about NCDs, and the countries have been worried about NCDs in the Pacific for decades, decades and decades. And there's been lots of different programs and lots of high-level statements and lots of commitments, but yet the obesity stays high. And this is another classic example of when we don't succeed when it's just health people talking to health people. So some of these other NCDs, you can do real important action, effective action, just in the health sector, like the stuff around smoking, like the stuff around better management of high blood pressure and high cholesterol. Trying to help countries and communities reduce the rate of obesity doesn't have a health sector solution. No amount of doctors and nurses lecturing their patients about eating less and exercising more will actually sustainably make a change. It can make a change for the odd individual. It won't make a change at a population level. And so what's really needed is to think about what are the broader drivers of that problem. And a lot of those drivers are outside the control of the health sector. Now, the health ministers in the Pacific, they meet every 2 years. And at the most recent one of those meetings, which was in Tonga in 2023, that was one of their big areas of focus, was on the drivers of obesity, particularly in children and young people. And a lot of the answer to that is actually around broader government and societal action, and really trying to address why a lot of the environments in the Pacific are so obesogenic. Bit of jargon for you, but why does it make becoming obese so easy? And so that involves things like tax policy, trade policy, whether people feel safe to exercise on the streets, or they think that the local dogs will come out and bite them if they start to have a bit of a run. I mean, all sorts of different things like that are what's needed, and we're at the early days in that. But the good thing is there's this clear commitment now. And also, for instance, the UN in the Pacific have adopted obesity as a whole of UN priority. So again, not just a health sector thing. It's all the different UN agencies all working with their own sectoral partners, looking at ways these other sectors can also contribute to what is a crucial, not just health problem for the Pacific, but it's also a development problem for the Pacific.
Speaking about priorities, we're about 5 years through, what the WHO termed in 2020 as the decade of healthy aging. And I know that this is a important topic in terms of the Western Pacific. There's a regional action plan that was put out a couple of years ago looking at healthy aging in the region, and you have quite a few, again, people aged 65 years or older. Just love to get your input again, looking at 21 countries, broad area. What are some of the themes you're hearing? We hear a lot, on the show about Healthspan and some of these this new jargon in terms of ultimately how we can sort of square the morbidity curve, keep people healthier a little longer. And then something quite fascinating that popped up on your website, and I only heard about this once before, actually recently, and this principle of social prescribing. We hear so much in the last year or so about the impact of loneliness and social isolation. How I forget, it's like smoking a couple packs of cigarettes a day. I was quite interested in seeing that the WHO has a piece on the supporting of healthy aging via this principle of social prescribing, in ways that a doc can write a prescription nowadays to, hey, go have some social interaction with other people. Take us into this. This is again another really interesting area that we probably don't have a lot of great solutions to yet, but a lot of innovation in the field nonetheless.
Yeah, I mean, in the social prescribing space, I mean, there hasn't been a lot of attention on that in the Pacific, and so far that I'm aware of. And I think people in the Pacific are generally pretty well connected. I mean, families are important, communities are important. There'll be some of the bigger urban centres in some of the Pacific countries where I'm sure there were people who are feeling very isolated, but it hasn't come up as a big priority from the Pacific countries so far in terms of what they're talking to us about. But some related things around healthy aging, but also around that sort of isolation, and actually relates to two big items that the ministers are going to be talking about at their next meeting, which is happening in September this year in Sama. One of those is on disability. And a big focus of that is on how to improve the access to different devices, different equipment, different things that help people with disabilities continue with their productive daily lives. Because that assistive technology, what we tend to think about, and that all sounds a bit technical and a bit obscure until we remember that things like spectacles are assistive technology. All sorts of basic things like that. And so, whilst also trying to tackle things like NCDs, which is the big driver of disability in the Pacific, also recognising that people who've already got disabilities, maybe as a consequence of the NCDs, they're not going to benefit so much from better prevention of NCDs, but they still have things that are the fact that they've had their foot amputated, for instance, or the fact that they can't hear so well, or they can't see so well, that interferes with their social connection and their ability to be productive. And so that's going to be a big focus of discussion. And hopefully the ministers will agree to a system in the Pacific to be set up to enable better access to those sort of basic things that so many people need, and so many people in the richer parts of the world get easy access to without even thinking about it. The other big focus at the upcoming meeting is mental health. Well, actually, it's mental health and substance use, and and the information on mental health in the Pacific is pretty patchy, but the information we do have suggests that is quite a big underdiagnosed issue. Now, there'll be lots of things that drive that, but loneliness and isolation will no doubt be a key component of that, at least for some people. But of course, it can be a two-way street, because people can have mental health issues because they're lonely and isolated, or they could be lonely and isolated because they've got mental health issues. So it's a closely related issue, and I think there's a lot more that we need to be doing and helping countries do in that sort of space. But yeah, but fundamentally, the single biggest thing to really support or to achieve healthy aging in the Pacific is helping get on top of NCDs better, so that people can actually not just live longer, but live healthy for longer.
Yeah, it's interesting seeing it. Because we do hear a lot about the age tech, tools and all that stuff that you were just mentioning in terms of the wearables and all that. And it's nice to see again that being a topic at one of these meetings coming up. So that's impressive. But what else is happening? You mentioned so there's another, what is a regional committee in the Western Pacific, I think, is coming up. You said later in the year in Samoa, I think October or so. I know one just happened, I think, in April. What else is on the calendar that we should know about in terms of what's happening in your region? Other initiatives, talks, conferences that you're going to be present at that we could potentially run into you if we head out that way, please.
Sure. So, in fact, there's actually two big meetings happening in the Pacific later on this year. The one in September is a meeting just of all of the Pacific health ministers. And that's the one that happens every 2 years. Then the regional committee meeting, so that's our annual governance meeting for the whole of the Western Pacific region. So that's Pacific and East Asia and Southeast Asia. That's also happening in the Pacific. So that's in October, and that'll be in Fiji. Whereas the Pacific Health Ministers meeting is in September in Samoa. So it doesn't happen very often that the regional committee meeting happens in the Pacific. So this is a big event, really. So that'll help have a very big focus on issues in the Pacific. But of course, the focus of the regional committee meeting is broader. Other than that, some other things. It's not so much meetings, but other things that have been going on that I think are interesting. One of the things we've been working on, it gets back to the resilience area that we were talking about before, because Pacific communities themselves are very resilient. Culturally, they haven't grown up expecting that somebody will come over the hill with all the resources they need if there's something that goes wrong. They are used to being self-reliant, which serves the communities and the countries in pretty good stead when they're put under stress. But that's not to say that there's not more that can be done to further strengthen the resilience and value that local capacity. So a good example of that, we've been working for a while now with countries setting up national emergency medical teams. Okay. And so, yeah, a lot of your listeners will be familiar with there's emergency, then you see all these doctors and nurses fly in with the tents and they set up and then they start meeting all of the health needs. And so we've now got, I think it's something like 13 or 14 of the Pacific countries have got their own emergency medical teams now, which have already got equipment already in place in the country. And so just one example of what that means in practice. When Tonga had its big volcanic eruption and tsunami back in 2023 that you might remember. And so that the same day that happened, the Tonga's emergency medical team was mobilised to go to the most affected island with all of their equipment. They set up, they assessed the health issues, they started meeting the health needs of the local affected population, all within like 24 hours. And in the meantime, of course, there were many other friendly countries all volunteering to help as well, and that was of course greatly valued, but there wasn't a need for them to send in medical teams because the local team had already identified what was needed, plus met the local needs as they existed. And so then we could say to the other countries, actually, this is what Tonga can say, this is what we need, but we don't need lots of other medical teams coming in because we've already dealt with it. Because if they had been relying on the other medical teams coming in, then it would have been some days before they could arrive. And so things like that are really important, and they're really practical, and they're really super valued by the countries because it's something that they are proud of having the capacity, and the clinicians that are part of those teams, whenever I'm visiting countries and I'm talking to them, they are also very happy they can be part of that, and that it's something that they organise and they deploy. So I think so that's just a practical example of the sort of stuff that we're doing. Another one people might be interested in, again, it started happening during COVID. One of the other ways that we've been working to try to improve the resilience of the services that health facilities provide is that in a lot of the countries, they've been reliant on, like for oxygen in their hospitals, they've been relying on importing cylinders of oxygen from other countries, which of course is super expensive and is a bit risky if something happens and then the ships stop coming.
Right.
And it's not easy to quickly scale up if suddenly you have a lot more people needing oxygen than you expected. You could quickly run out. And so in quite a few of the countries, we've set up, again, containerized, like laboratories, but containerized oxygen plants. And so they've been installed in a lot of the bigger hospitals and even some of the provincial hospitals in some of the Pacific countries. So now they can make as much oxygen as they need, and it's saving them a whole lot of money, and it's making them a lot more resilient, and the quality of care is much better. So anyway, so it's practical things like that we try to work on, and that produce a sustainable benefit rather than something that is only useful during the emergency and then it stops being used. And that, which gets back to some of the stuff we were talking about earlier on around health security. So what we try to do is stuff that doesn't just work for one disease or one issue or one event. It's something that is useful not just during future emergencies, whatever they are, but also for day-to-day work of health systems.
Yeah, and I like how we just went full circle and came back to the all hazards principles, and yeah, it's extremely impressive, Mike. I got to say, and again, thinking about the scope of what you're involved there and where you're taking it, it's very impressive, and I very much enjoy listening to where you started out and where you're going with this, but a very impressive story. And I'm going to look forward to see how, again, everything continues to progress in your region, but really, really enjoyable discussion. Again, for everybody that is going to be listening to this episode of our show across the various podcast networks, or who will be watching on the YouTube channel. Again, you've been spending time with Dr. Mark Jacobs, Director of Pacific Technical Support, WHO representative to the South Pacific, doing really amazing things to strengthen disease surveillance, strengthen all hazard emergency preparedness, overall enhancement of resilience in the sector to improve health and develop healthy public policy. Mark, I really want to thank you for taking the time to walk through this journey you've been on. It's extremely impressive. I say thank you for everything you do. And as we like to say on our show, thanks for helping to create a better tomorrow for millions of people out there via this type of work. Really very impressive. And I look forward to continue to follow your story.
Great. It's been my pleasure. Thanks very much.
Really great.